So I farm so hard the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z.
What's good, fam? This is your host, Jim Pruitt, aka PharmD in the ED, and I'm bringing you another episode of the Farm So Hard podcast. Today, we have another special episode, and it's something that's going to be applicable to many pharmacists, nurses, providers out there, especially if you're working in a trauma center. We're talking about open fracture antibiotics, and I have a phenomenal guest on that's going to go ahead and introduce yourself.
How's it going, Jimmy? Thanks for having me on the show today. My name is Rob O'Connell. I'm an emergency medicine clinical pharmacy manager at SBH Health System in the South Bronx.
Perfect. So I want to go ahead and get into some of the speaking points and jump into the episode so we can make this really succinct. So can you just explain to us, like, why is this topic even important?
Sure, Jimmy. Yeah. So, we know that accidental injury is one of the most common causes of death in the United States for individuals, younger individuals, those like 1 to 45. And falls are one of the most common reasons for hospital admission for patients in the older generation. They account for up to 87% of all fractures that we see. And open fractures are typically high energy injuries. And we know that these are associated with increased risk of infection due to potential exposure to bone and deep tissue and various environmental debris that might get in there.
Absolutely. What I usually see is these people come in and they're like, it's a 13-year-old that was riding an ATV and it's a tib fit fracture and it's sticking out and they're just walking in, just looking crazy like, oh, this bone is not supposed to be here. So when I look at that, I'm thinking to myself, what antibiotic? What do I need to get involved in? But before I get to what antibiotic, one of the key steps that I always ask my trauma providers, I say, what class of fracture is this? And this is going to be the Gustilo and Anderson classification. And most people hear you say type 1 or grade 1, grade 2, grade 3. Can you go a little bit and describe what is a Gustilo Anderson classification of open fractures?
Yeah, so we're going back in history here a little bit. This goes back to the late 70s, early 80s, where Gustilo and Anderson kind of came out with this classification system based on some of the data that they looked into as far as treatment and antibiotic selection to kind of break down what we're potentially looking at here as far as what we need to cover. So they came up with this grade 1, 2, and 3 categories. 1 basically being our small, less than 1 centimeter injuries. These are simple fractures, minimal soft tissue damage, typically called like poke hole injuries, where that fracture occurs kind of inside and the bone might just start to be sticking out. Now, as we go from grade 1 to 2, we're talking about bigger injuries here, somewhere in the 1 to 10 centimeter. Again, still relatively simple fractures with maybe some moderate soft tissue injury. Now when we get into grade 3s, now we're talking about our really bad open fractures, those ones where the skin is kind of blown wide open, bones are sticking out. And this is further broken down actually into A, B, and C. This, again, as we go up from A to C, we're talking about getting worse and worse to the point of grade C fractures being associated with vascular injury. These patients are going straight to the OR pretty much in all the cases. So in these cases of grade 3, we're talking about, again, further soft tissue injury, likelihood of much higher rates of infection. We got to cover maybe for some broader spectrum bugs here.
Absolutely. So we know now what the different grades or different types that can be. And when I went back and started reviewing some of the data, I had to ask myself, why was it so important that we get these antibiotics in within a certain time frame? And the infection rates are a real deal. I think we don't necessarily always understand the risk of infection with these injuries because we see it so often. So can you go and elaborate a little bit more on the infection rates for open fractures?
Yeah, so you're going to see definitely some various ranges based on the studies and the literature that's out there. But for those grade 1s, we're talking like pretty minimal risk, somewhere in the maybe even 0% to 2-3% risk. Type 2s, we're seeing more like 5 to 10% chance of infection or so. Then we go up to grade 3s. We're talking anywhere from like 12 to 50% of these patients are going to end up with some sort of infection if we don't treat them adequately and effectively.
So you're saying that if for a grade 3 fracture, that potentially 1 in 2 patients, if we don't do a good job as a ED pharmacist or pharmacist in general, or as a team, 1 in 2 people can develop an infection. That's crazy there.
Yeah, that the numbers are quite high, and I think like you said, it was something we see all the time, especially in a trauma center. We could kind of get into the flow of just moving these patients through the trauma bay and getting ortho involved and surgery involved, and antibiotics definitely get slipped through the cracks. It's something that I always make sure to talk with my new nurses about for when I'm not there. That these patients need to be treated before they go upstairs, before they go to the CT scanner, before they go to X-ray for all those films that we're going to get on these patients. The antibiotics need to get in the trauma bay.
Yeah, and this is as we think about this, the antibiotics everyone usually hear, you're going to see ANSEF and stuff like that. And as we talk about the grade 3s, there's been like a transition. And I think this is where we actually got involved with the brain and vein challenge, when speaking about, scratch the Gent, let's give her a 7 for the open leg. And so can you go back and just talk about what was the initial antibiotics we give, and particularly looking at some of these grade 3 options?
Yeah, so this is definitely, I think, a hot area and kind of the crux of this talk here. You throw it back to the main guidelines that we follow, the East guidelines. These historically tell us that in grade 3 fractures, we're looking to give our ANSEF, our class 1 cephalosporin to cover those gram-positive agents, and then add on something for gram-negatives. And this has kind of always been taken as add-on Gent. And now that's being challenged a bit here as we kind of move forward. And aminoglycosides, I don't know about you, but I don't like them. I don't like to deal with them. I don't like to make them.
It was such a hassle. At my previous shop, I actually had to get consulted for every grade 3 fracture. I had to get my personal mix of Gent, go to the bedside, next compound Gent for every patient that required it. And I've only worked at like large level 1 trauma centers. Like, I don't have time to make Gent for every single one, because Gustilo and Anderson did it back before my mom was born. I just I just think it's crazy that once we start to identify what extensive gram-negative coverage meant, we just went completely with Gent and nothing else, because they used it back in the 70s. So I think this is interesting. This is what really brought this to make it a hot topic, because we just continued to do the same thing over and over and over again and never challenged it. So also, can you talk about what the East guidelines said for just the other fractures and duration?
Yeah, so duration is definitely another area that we want to talk about. So typically we're talking for our grade 1s, we're looking at maybe 24 hours of coverage once that wound is closed up. Now we know that we're talking about bigger infections, bigger tissue injury, maybe some vascular injury for those grade 3s. And here's where we're likely continuing antibiotics for about 72 hours once we're clean and closed.
So we really went back through some of the history of open fractures. Then we talked about, duration and infection rates. And I think most people just want to get to so what in the hell should we use? Like, you're telling us that we're using the wrong antibiotics and that Gent is bad, and somebody's grandma going to come and stab me in the throat because they've been giving Gent since the 70s and 60s. So if we had to go through and say, all right, for a grade 1 and 2, no additional caveats, what would be your preferred agents? What do you have for severe beta-lactam allergies, and then so forth?
Yeah, so grade 1 and 2s, we're pretty much sticking here with our cefazolin, our ANSEF, our kind of bread and butter situation. Now, when you get down to dosing, I think this is something that you might see some variation. We're talking weight-based dosing here. We want to make sure we're getting these patients adequately treated based on their weights. Typical cutoffs that you'll see are anything less than 120 kilograms. We're using 2 grams. You might see some lower cutoffs. Some people I know like to go with less than 80 kilograms. They're using a 1 gram dose. And then for those larger patients greater than 120 kilos, we're using big doses of 3 grams of cefazolin. I think this is another area where different guidelines kind of have different breakpoints. I've seen people refer to the ATLS guidelines. which uses actually a little bit of a lower dosing cutoff ranges. ATLS is less than 50. We're going to use a gram. 50 to 100, we're using 2 grams, and greater than 100, we're using 3 grams. So again, another area where there's definitely some variation, but we want to make sure that we're kind of adequately dosing these patients. In a prior center that I worked, it was always 1 gram of Ancef, 1 gram of Ancef. The data supports using the higher doses. So I think it's a big push to make in any trauma center, really, maybe even more so in our community centers that might not see these as often, making sure that we're adequately dosing our patients.
And they probably use that same 1 gram because the resistance rates back in the 60s and 70s were not as bad.
Yeah, I think that definitely might be part of it.
So if there's like a patient comes in and say, oh, my grandma was allergic to penicillin, and I usually see this come up quite often where they just don't want a beta-lactam. What's your go-to then if you don't have, if you have to switch over to something else?
Yeah, I mean, well, I think you bring up a good point. I mean, here in the South Bronx, it seems like everyone's got a penicillin allergy, but no one knows what it is or when it happened. They were just told that when they were a kid. So I think this is another area that we could certainly be involved in, making sure we're educating our providers about the low cross-reactivity and cross hypersensitivity between a true penicillin allergy and our Ancef, or maybe some of our 3rd generation cephalosporins as we go into them. But your team you're telling me is adamant against beta-lactams. I think it's pretty good consensus that Clindamycin is definitely an option. Most of the guidelines are kind of pushing that direction. But again, using big doses, 900 milligrams is typically what you'll see for those grade 1 and 2s.
Cool. And it comes up so often. I tell people, you probably don't have an allergy, but they just say, I don't want to have to go down that route, and I go with the Clinda. But most of the time, I think that if we are doing a great job and we have the time, we can go ahead and solve a problem that can go throughout their entire stay. Because now, I don't know how many times you've seen it, but when patients get clindamycin for multiple days, they end up getting C. diff, or they end up having some type of, megacolon. That becomes a huge issue that we could have prevented the very first 20 minutes of this patient's presentation. So I try my best to get that off board, but it is amazing how much money, how much time, and how many patient-oriented outcomes you can prevent by getting a simple, accurate history.
Yeah,
and
absolutely.
Then another component that I probably should do a better job at is going back and looking to see, have this patient recently been to my facility or any other facility, and are they colonized with MRSA? So if that was the case, do we just use clindamycin for that, or do we use something else?
Yeah, so I think you bring up another good point here. I mean, MRSA is definitely something that we're concerned about. Some of the older literature does show that some of these patients do end up with MRSA infections. I think my site in these patients, if we know they're colonized in MRSA, we're going to Vanco on these ones. I would say look at your local resistance patterns. At my shop, clindamycin and MRSA is just a no-go. Our resistance is super high. So we're pushing for vancomycin in these patients.
Absolutely. And I would agree. If I know, that's a really cool intervention too. Like I tell pharmacists that I train now, I say, hey, if you want to look cool in front of your orthodox or your trauma attending, if you can go and say, hey, this patient has a past medical history that's significant with MRSA colonization, I actually think we should upgrade to using vancomycin. That makes you like a superstar. There's a few things that's like really cool from a pharmacist, but if you can go back, find the information, provide it to the team, that's a super recommendation there. That's a pharmacy pearl right there. All right. So grade 1 and grade 2s are pretty cool. We can give them Ancef, we can give them Clinda if they absolutely can't get a beta-lactam. And if that's the case, if they have MRSA colonization, we can do vancomycin as well. But let's get to the star of the show here, the grade 3 fractures. Like, should we just give Gent, or is there other agents that we can give to treat the grade 3 open fractures?
Yeah, so this is something that I made a big push for a change here at my shop to get away from that Gent. Now, when we look at our antibiograms, our Gent coverage is great. We're covering all the gram negatives with Gent. And so we say, well, what's the problem here? Well, if we throw it back a little bit, we already talked about kind of adequate dosing. but the real big bread and butter is timing of these antibiotics. And I think this is what I use to kind of make the switch here at my shop. And people really bought into, especially when we showed them the data and our own in-hospital data as well. Gentamicin, we already talked about making it at the bedside, getting consulted. This is a weight-based dosing that's got to go up to most IV rooms to be prepared, patient-specific. I don't know about you. We don't have a tube system either here at my shop. So I don't know who's running gentamicin up and down for every trauma that comes in. But I'll tell you that antibiotic is not getting into patients in a quick time. And when we looked at our older data, again, throwing it back to the 80s, we found that timing of antibiotic administration is super, super important. There's some studies that showed Lack and colleagues in 2015 specifically, they looked at antibiotics for grade 3s, and they found that if you gave antibiotics in less than 60 minutes, we had about 6-7% infection rate. And those patients that got antibiotics beyond 90 minutes had about a 28% infection rate. Yeah, so we looked at our data here at our shop, and our gentamicin administration was closer to the 3-hour mark for these patients.
And that's the thing that most people don't want to talk about. Just because you push a button in your Epic or Cerner or whatever system you use doesn't equal a patient getting that antibiotic within an adequate period of time. And usually pharmacists, we can say, you know, hey, we can help out with that, but it takes so much time away from the other activities we can be involved in. And from a system standpoint, it's just not sustainable to try to give these patients Gent because, you know, somebody in the 70s did it. That's the only reason why. So I think it's amazing that you actually looked at your shop and seen that. And for me, when I came to MUSC, we had ceftriaxone as IV push already. So not only did it not have to come from central pharmacy, I could get it pushed in less than 3 minutes. Like it was simple. And it covered gram negatives very well. So I think this is another thing that came out. And there's actually a study that looked at this. So Rodriguez and colleagues in 2014, they reported like a decreased use in aminoglycosides and glycopeptide antibiotics with no increase in soft tissue infection. So we basically just shown that, okay, with real data, with evidence-based practice versus emotion-based practice, that we can actually treat these patients adequately with something that's easier, not just for me, but that's safe for the patient. So I thought that was pretty cool. But now that we know we can use ceftriaxone instead of gentamicin, what happens if their great grandma had a beta-lactam allergy and they refuse to take a beta-lactam, even a cephalosporin? What's your go-to then? Because this is an interesting thing that comes up every once in a while. Yeah,
and you're definitely kind of getting into that unique patient population here. Again, making the push for verifying those allergies, making sure we're all on board here. But we still got to cover those gram negatives. You want to avoid Gent. My shop has kind of gone to a clindamycin plus levofloxacin situation. I know fluoroquinolones are kind of a red button topic to begin with, and we could get into that in a whole nother discussion, I think. But there is literature to support that. A lot of the guidelines out there kind of have gone in that direction as well. So yeah, using Clinda and Levo is our next line for those grade 3. Yeah,
that's another unique situation where I think pharmacists out there, or whoever's listening, you can be a rock star by saying that, oh, if you can't use this is like the next line agent we can use. And that's a component that we can think of. So now that we went through the generic, grade 1, grade 2, grade 3, there are some additional caveats that usually come on, and you got to add some coverage for contamination with soil or fecal material. So once you get that, staying with the premise of using, staying away from Gent, what's your go-to then for these patients?
Yeah, so for soil and fecal, we're talking mainly about Clostridia, anaerobes, right? Mm-hmm. So my go-to here is ceftriaxone and Flagyl. This has kind of been our go-to here in the Bronx. I mean, we don't have those farming injuries that might happen out in the middle of the country. There's not too many farms here in the South Bronx, I don't think. But you never know what might come in. We definitely have dirty injuries. We got some scooter accidents on the streets here in the city That's been a big one this past year. So those really dirty wounds that we might be worried about anaerobes, we're added on Flagyl for those patients.
Perfect. So we got that. And then are you just using levofloxacin still as your agent if they have a beta-lactam allergy and adding on Flagyl?
Yeah, that's been our go-to here at my shop.
All right, perfect. So we got grade 1, grade 2, grade 3, some soil contamination. Another interesting thing that happened for me, because I'm sitting right here, like literally on the beach. I'm sitting here, like tons of lakes, tons of oil, tons of water around. So is there any additional coverage we need for like standing water?
Yeah, standing water, definitely something that I think you down on the beach need to be worried about. Usually in these patients now we're looking to cover for like Pseudomonas, some Vibrio species. We're getting into some unique bugs here with that. These patients, a lot of times they're going broader spectrum here to cover that Pseudomonas. We're talking Zosyn, we're talking Doxy for the Vibrio. That's pretty much our recommendation here. I know some people go with Cefepime too to cover that the Pseudomonas. So I think that's also an option.
Perfect. And then since we're staying with the same theme here with a beta-lactam allergy, if you got all this going on, it's starting to get really tricky here. What's going to be your agent with all of these things going on with a severe beta-lactam allergy?
Yeah, we're talking at our shop go with Levo and Flagyl here for those kind of beta-lactam allergic grade 3 water infections.
All right. So guys, pause the show. Everything you're doing, we're getting ready to give you the most important medication in the history of trauma. The most important medication. I say it again. This is going to be groundbreaking. We're talking about tetanus.
Tetanus, number one.
The number one most important medication in trauma. Well, if you make it based off the intensity that the trauma team wants that tetanus in the patient.
They are adamant. I have never seen anything like it, but I've been in 2 different level 1 centers now, and man, the amount of tetanus that we go through, keeping those Pyxis machines stocked is something else.
I'm going to tell you guys a little secret. I actually keep like 1 or 2 tetanus in my pocket, every time I hear a trauma activation. So I'm not walking around for you admin out there warming up the tetanus, but every time I get a trauma activation, I slide 1 or 2 of them in my pocket. But what's the caveat for this? Because I think there's a certain number of years that we categorize whether or not we should give an update that tetanus vaccine.
Yeah, so I think what you're getting at here is for those breakpoints between like clean wounds or those really dirty wounds. So for those clean wounds, we usually say anything within 10 years, you're good. For those dirty wounds, we're going to bring that down a little bit to about 5 years. I don't know about you. A lot of my patients we talk to, they just don't know.
Yep.
I do not know. I don't even know what you're talking about.
And now we just slide that tetanus right into their right delt. That's usually my go-to. Like, well, today it's your lucky day. I'm giving you the most important medication in trauma history. So we really went through a lot of that. And just to summarize that for your grade 1s, depending on what shop you're at and what guidelines you're going off of, you're going to give anywhere from 2 to 3 grams, and there's some lower cutoff ranges anywhere from 80 to 50 that some places may recommend giving 1 gram. Your beta-lactam allergy for grade 1 and 2 is going to be Clindamycin 900 milligrams. And if you have a known MRSA colonization, it's going to be Vancomycin. Loading them and then get your pharmacy to dose. Moving forward to our grade 3s, ceftriaxone is now dethroned gentamicin. So bye-bye Gent. Let's scratch the Gent. Let's give us Cefam for the open leg. That's what we're doing from that. And cool thing, if you have a beta-lactam allergy, we're looking at clindamycin plus levofloxacin. And then the add-on for contamination with soil or fecal matter, we're talking about ceftriaxone plus Flagyl or levofloxacin plus Flagyl. And lastly, looking at contamination with standing water, we're looking at pseudomonal coverage with Zosyn or Cefepime. And then if they have an allergy, levofloxacin and Flagyl. And of course, guys, 10 years for a clean room tetanus, 5 years for a dirty room tetanus. So before I want to head out, this is a ED pharmacy show. So I wanted to show us some love here. Is there any data out there that says that PharmDs in particular involvement in trauma actually help with antibiotic selection? Is there anything out there that's been published?
Oh, absolutely. I think our our ED pharmacy colleagues are always looking for these types of studies. This is like our bread and butter, right? Time to medication administration, and choice of agents, everything like that. This fits in perfectly. So Harvey and colleagues in 2018 published an awesome study looking just at this in the Journal of Emergency Medicine, where they looked at ED pharmacists' impact on time to antibiotics. And guess what they found? They found that before the guideline recommendations, with having a pharmacist at the bedside, they went from 81% to 41%. As far as time to door to antibiotics, they dropped that to 14 minutes.
Man, I can't even get a turkey sandwich that fast. And you saying we can get antibiotics into a patient. So again, it's another way that, you know, we go from almost half of the time the antibiotics being right to more than 3/4 of the time the antibiotics being correct with our PharmDs there. And again, median doors for antibiotic time of 14 minutes. You may not be able to get a CT that fast. And all my ED, physician colleagues know that that's like their number one intervention, the donut of truth. And so if you're telling me I can get antibiotics in you, and not only antibiotics, but the right antibiotic in you in 14 minutes, that's going to be phenomenal. Well, I thank you for, all your support on Twitter, all your support with everything we're doing here. You have any final thoughts or final words for the audience as we get ready to close out?
Yeah, I mean, always look to bring this data to the administration. This is kind of what helped get this protocol in place here at my shop. I sit on the trauma operations committee. This was a no-brainer. Once I showed them how long it was taking to get that Gent in, if you're worried about gram-negative infections in these patients, well, waiting 3 hours for a dose isn't doing the job. We want these patients treated ASAP. We got Ancef, we got ceftriaxone sitting right in the trauma bay Pyxis machine, easy to go, IV push, just like you said. This is a no-brainer. If you could put the data in front of the people, you can make it happen.
Absolutely. Well, again, we definitely appreciate you for coming on the show. This is a really cool episode because I think it's something that we all go through, but no one's really touched on a significant amount. And I really appreciate adding the managerial component to this, so our audience can know that whether you're practicing at the bedside or you're working in a more administrative role, this type of information and data can really help you guys. So get ready, guys, for the Empower conference that's going to be in March of next year. I sent out some surveys on Twitter. I sent it out to a few different places. So definitely respond to that and let me know, what do you want to hear? Who do you want to hear? And do you want to hang out together? So definitely check out that. If you have any questions, find me on Twitter at PharmD_in the ED. Definitely click and subscribe to our podcast on Spotify, on Apple Podcasts, and all of those avenues, because it really helps us out. And we want to put this out there for more people. We want to have the #1 pharmacy podcast in the world. So as I always say, guys, you don't have to work in the ED. You don't have to be a pharmacist, but everything you do, make sure you farm so hard.